Good afternoon, everyone. We're going to wait just one more minute to let some people in, and then we'll get started. Good afternoon, everybody. Welcome to another month, another Lunch and Learn. We are glad you're joining us here today. There's only a few more after this one, and then we are completely done, which is exciting to get this over with. Not over with, but excited to be done. We can all get our credits. Speaking of that, I have an email ready directly after this with some reference links and the link you need to fill out your quiz to get those credits. I'm going to try and send that out right after this webinar ends, so we can just get ahead of the game in that way. Without further ado, here's Carrie Flint with our Lunch and Learn for the month.
Thanks, Zach. Well, welcome everyone. It's great to be here. I hope everyone had a bit of a rest over the weekend. So for those of you who have not joined us before, just a quick reminder about the Zoom platform. So you'll all be muted during the presentation, so please use the chat feature to be able to let us know what questions you might have or any thoughts or comments that you might have during the presentation. Again, just a reminder about where those functions are found on your screen, although they may have changed with updates and things by now. So again, thank you for attending this month's session. Again, for those who are new to join us, these sessions have been hosted monthly over the last several months, and we've covered a different topic each month. And so the structure is we do an education session, and then it's followed by an open forum session where you can ask questions, share what's going on with in your world, and seek some support from your fellow IPs. If you have a question, it doesn't have to be related to the presentation. We may have an immediate answer, or we may need to do a little bit of research in the background. So we'll get back to you if that's the case. So go ahead, next slide. So this is just an important announcement. It's the disclosure slide, just letting you know that the New Mexico Healthcare Association is the approved provider of nursing continuing education credits, that participation and completion of the evaluation is required in order to get those credits, and that I have no conflicts of interest to disclose. So a quick introduction. My name is Carrie Flint. I've worked in infection control for a number of years across a number of different settings, and I'm an executive consultant with ICCNM, which is a consulting company. I am a nurse by trade and have an educational background in public health and epidemiology. And so again, it's great to be with you all today. So today we're going to be taking a look at ultrasound devices. This has definitely been something over the last couple of years, I think, that has gained a lot of interest and conversation, and I'm sure many of you have made changes into how you manage ultrasound in your facilities. And so this is really kind of just taking a little bit of a deeper dive into ultrasound devices, where we find them, and some of the recommendations around them. So let's start by just taking a look at what ultrasound actually is. So the ultrasound is a diagnostic tool that's been around for more than 70 years, really. The technologies actually come from sonar that was used for sea navigation back in World War II. And so we have the ultrasound sort of ways that we use it falls into one of two categories. Either it's used for diagnostic purposes or therapeutic purposes. And so most of us are familiar with the diagnostic ultrasound as a non-invasive technique that's used to image inside the body. The Society of Diagnostic Medical Sonography cites ultrasound as one of the most frequently used forms of imaging for diagnostics. And the handheld probes, referred to as transducers, produce sound waves with frequencies above the threshold of what the human can hear. And then today's ultrasounds are even, more sensitive and operate in the megahertz range. Most transducers are used on the skin, so they're external, but some are placed inside the body, either by the GI tract, vagina, or through blood vessels. And then we have our therapeutic ultrasound. Also is very similar in that it uses sound waves above our human hearing range, but it doesn't actually produce images. So its purpose is to interact with the tissues in the body. So we'll talk a little bit more about that. So when we talk about ultrasound, there's some standard equipment, particularly when we're talking about it in terms used for diagnostic, but there's usually a scanner, and it consists of the computer console, which many of you may be familiar with in this picture. There's a video display screen that you can see the image. There's the transducer, which is the device that's used that sends out the sound waves. And then there's what we call coupling gel, or often it's referred to as ultrasound gel. And so those are the three or the four main components of our ultrasound equipment. So again, just taking another look at our diagnostic ultrasound, it's again non-invasive diagnostic technique, designed to look inside the body. The ultrasound produces images of the organs or the other structures that are being looked at. And so the functional ultrasound combines information such as movement and velocity of tissue or blood, softness or hardness of the tissue, and other physical characteristics. And so we often think of these in terms of like our Dopplers and our color Dopplers that are they're used in cardiology clinics when we're looking at blood flow and flow within the blood vessels. So in comparison, we have therapeutic ultrasound, which is often referred to as interventional ultrasound. Again, it's tends to be very specific, so it's targeting specific areas. It can be used to heat, ablate, or break up tissue. There's also something called high intensity focused ultrasound. And this is sort of a new technology where they're really looking at how they can modify and destroy disease or abnormal tissue in the body. So things like tumors, without having to actually go in and, surgically remove something, they may be able to do it through ultrasound. And so currently high intensity focused ultrasound has been approved by the FDA for the treatment of uterine fibroids as a pain relief method for bone metastases. And then it's also been recently approved for the ablation of prostate tissue. It's also being investigated as a way to close wounds and stop bleeding, and for breaking up clots in blood vessels. And then another interesting use is that they are looking at is to temporarily open the blood-brain barrier so that medications can pass through. And there's also, I did come across an article where they were looking at this for the bladder as well, to be able to increase the barrier for medication use. And then it's also used in in physical therapy. So this is where what they say happens is that the temperature of the tissue warms up, and so it can help accelerate metabolism and increase blood flow. It's very interesting though, there's some controversy about how effective this type of therapy actually is, but it still seems to be a pretty popular treatment mode. And so you will find ultrasound equipment, oftentimes in physical therapy departments. So as you may have noticed on the previous slide, there's multiple, you know, on that little image back there, there was multiple transducers, shapes and sizes. And so this is really just, if you think about what you've seen maybe on an ultrasound station, the different types of and shapes of the transducers. And so this just provides an overview of what they are. So we have sort of the straight line linear type. It's good for looking at very superficial structures. We have the curved one that most people I think are familiar with, particularly in like the OB areas, where it's used to monitor like fetal heart tones and get you know, images for that. There's also sort of a larger, wider, which is called a phased array or sector. And so it's used for looking at thoracic structures in the chest, mostly because of course, it's a, you know, it's kind of, our chest area is kind of curved. And so it helps to get a better, better imaging. And then we have our endocavities. And so these are usually the longer probes, or the ones that sort of almost look like more scope-like in appearance, that are used for looking at internal structures. So along with the different types of ultrasound use and the types of equipment in terms of transducers that's out there, there's also a variety of different people who are actually performing ultrasound. And understanding who's performing it can really help identify where ultrasound is being used in your facilities. And so we have sort of the most obvious places that it's happening. So we have our diagnostic sonographers and our ultrasound technicians. And so we tend to think of those as working primarily in our radiology departments. They may be in vascular labs. They may be in your OB areas and in your cardiology areas. We also have nurses performing ultrasound, and that includes our patient care techs. And so oftentimes this is associated with bladder scanning. So, you know, when that's often one of the main uses that it's used in clinical practice. And we're seeing more of that as we've done more work with removing Foley catheters timely and things like that. Physicians can be using them, radiologists, surgeons may be using them. PIC teams, so people who are doing PIC insertion, so they may not necessarily be nurses, they may be respiratory therapists or other members of the PIC team. And then we have our physician's assistants. And this is just a small list. So again, just thinking about who is doing it in your own facilities and the type of training and education that they may have had around all of the elements associated with ultrasound, not just performing it, but also the cleaning and disinfection of the equipment. So this is a slide or an image that was taken from an article that was published in the American Journal of Infection Control. And so the reference is here, but it's also on the reference list you'll be sent. But this just really highlights where the ultrasound has been reported as being used. And so this was actually information that was collected during a survey to look at, you know, where and who was doing performing ultrasound. And so you can see that radiology and OB/GYN areas do have the most, but it's interesting to see some of the other different places that you might find them. And so it's important to think about, you know, not just your inpatient, but any outpatient areas that you may be overseeing as well. And so there's pretty much, there's quite a large number, and pretty much all specialty clinics in some way are using ultrasound in some capacity. So some of the risks that are associated with ultrasound procedures are, from an infection control perspective, are typically associated with inadequate cleaning and disinfection, and outbreaks associated with contaminated ultrasound gel. Oops. So we're just going to take a look at some of the sources of risk. And so I want to just take a couple of minutes to kind of look at this particular slide, and feel free to put into the chat any risk factors that you think might be occurring in this particular image. We'll just give people a minute or two just to kind of take a look and put their thoughts together. So I see some things coming in: open gels, uncovered probes. Yeah. So there definitely can be a lot of opportunity around these somewhat, really common pieces of equipment. So let's take a look at some of the infection risks that have been published, that are out there. I've actually been involved where we really had to, as a department, had to really prove that ultrasound probes and gel were a potential hazard, and that we should be following the latest guidelines and recommendations. But there's just a couple of studies. They've really been around for really since the 90s. There's been a number of articles, but these are just some that are a little bit more recent. Where ultrasound probes have been identified as a possible vector of transmission. And so these particular authors found that, they felt that the deterioration of the probe and then inadequate disinfection were contributing factors. And then another one was just which has really, I think, highlighted some of the issues around, particularly the vaginal ultrasound probes, was the risk of HPV contamination, and that this was not a well-recognized method of transmission. And understanding that many of the ways that we were previously disinfecting were inadequate against this particular virus, the HPV virus. So this was another study that happened. It's actually was published in 2018, and this was a Scottish study where they actually looked to evaluate the risk of infection using microbiology reports and antibiotic prescriptions as a proxy measure of infection. Obviously people don't develop infection immediately after having had a procedure, and so it happens sort of a little bit maybe a week, 2 weeks, a month later. And so they looked at the risk, and you can see just from some of the results that they found that positive microbiology results, there was an increased risk of having that happen following transesophageal ultrasounds, which was a pretty significant hazard risk of 4.92. But again, transrectal and transvaginal were risky activities. And then looking at the amount of antibiotics that were prescribed. And so this is obviously going to be lower, but I thought this was interesting because for many people, they may not go back to their provider and really for it to be identified that they needed antibiotics and it was related to having had this specific procedure. So, but again, there seems to be, somewhat of a risk associated with these types of procedures. So a little bit about HPV. And so it was recognized that that they are resistant to glutaraldehyde, and this was had been a pretty common agent to disinfect our probes that we were using. And so many of you may have been in OB wards or units and seen the little holders hanging on the wall of the utility room that was where they were using the OPA to disinfect. So HPV, it's a causative agent in cervical cancers, but it's also associated with cancers related to anogenital and oropharyngeal cancers. So it's not just vaginal probes that are at risk. And then again, just recognizing that some of the other types of disinfecting agents are more effective. And so there was concern for, based on these studies and the resistance that was noted with HPV to the glutathione, that there was a potential for transmission of the virus from fomites, so from surfaces or contamination, and non-sexual transmission, so obviously the probes. And so there's a couple of articles there, and those are also included in the reference list. So contaminated ultrasound gel has also been a source of outbreaks. There's two sort of main ways that it happens. There's a risk of contamination at this point of manufacture. And then there's the risk of transmission where we have sort of inoculated. So thinking back to our open gel bottle there, and how we use the gel is important. But there's definitely been articles reported in the literature about it, both for and particularly with the sterile, and so it's obviously important to be aware of these types of things, and just in vulnerable populations. And I think both of these studies were actually in intensive care units or neonatal areas where they were doing central lines. So there's been a number of articles around those infections and what's sort of sources of contamination, and so obviously how we store them. We often can't do much about the manufacturers other than just be aware that it can happen. And so if we're seeing some unusual infections or sort of outbreaks of infections, that should be something to consider, depending on where that infection is occurring, that it could potentially be a contamination at the point of manufacture. But oftentimes it happens more in once there's the bottles and tubes are already in use. And so back in the day, we used to use these huge big bladders of ultrasound gel, and we would just refill the bottles. And so that was a pretty standard practice until these articles and this information started to come out. And so in many cases, in some particular areas where the ultrasound procedure is not perceived to be very high risk, you may still find these large bladders of ultrasound gel being used, and them in themselves may not be an initial source, but the risk of contamination happens at various points. So when we're refilling the bottles, obviously if we have a contaminated bottle that we're refilling, we're just adding additional food to something that's already growing, and so that's the use of those bladders is not recommended, but you will still find them. They still make them, and so they're a much more cost-effective option for people. And so many times in clinics or freestanding facilities, they may be using that. In general, most people are using the reuse, like the bottles. So they're used for multiple patients. So they stay on the machine, and then once they're empty, they're just disposed of. So ideally, some of the recommendations that came out from this particular article, which was also published in the Shea Journal, was that single-use sterile gels are recommended for any time you're doing an invasive procedure, such as a biopsy or a puncture. Any procedures where you're using sterile equipment, anytime that you're having contact with non-intact skin or intact mucous membranes, near fresh surgical wounds, any sort of high-risk population like a neonate, and it would always be the optional choice, but it's expensive, you know, to do that just as general practice. So then there's the non-sterile, and so this is where you might see the bladders, the bottles, but there also, you know, there's more use of the non-sterile individual packets happening now. And so again, it's suitable for non-sterile, intact skin, and ideally you don't want to be refilling those containers, because the reality is that no one is washing, you know, that bottle in a warm soapy water, allowing it to rinsing, allowing it to air dry before they're refilling it. So it's just important to be aware of kind of what's being used. And what you'll often find is that multiple departments are using multiple different types of ultrasound gel sources. So some may be using sterile, some may be using bottles, some still may be using bladders. And so one way that can be really helpful to kind of get a handle on this is work with your supply chain, because often being able to standardize what you're using is a great way to, again, make sure that everyone's doing what they should, but it's also attractive to that particular group by standardizing and having, you know, just one or two products instead of a variety. So this is just a slide that's highlighting the sources of potential pathogens and so where you'll find them. So obviously our skin, we have our coag negative staph and some other, you know, friendly bacteria, but you know, we have some very specific things that tend to show up in our throat and upper airways. E. coli is often in our GI tract, along with some of our enterococcus bacteria species. And then, you know, things that are typically found, you know, around the genitalia and the vagina. So having this sort of guide can be helpful if you're starting to see particular types of pathogens showing up where you're sort of surprised that you'd be seeing infections in those areas. So leading to the types of pathogens and where we might find them takes us to looking at how we're classifying these different types of equipment and where they're being used. And so I'm sure many of you are familiar with the Spalding classification. So we have our critical items. So that's those objects that are normally entering sterile tissue or going into the vascular system, so they require sterilization. We have our semi-critical, which are those that are having contact with mucous membranes or skin that's not intact, and so we use high-level disinfection. And then we have our non-critical items. So those items that are only touching intact skin. And so this is the recommendation from the CDC's disinfection and sterilization guidelines. And so they have been around for a long time, but they did update some sections in 2017. And so just something to be aware of if you haven't looked at that in the last few years, or you have an old copy of it, there are some updates. So this is a study where they looked at sort of the contamination that was happening. And so they did a blinded study. This was actually conducted in Australia. So they took swabs from transabdominal and transvaginal from cords, so like electrical cords, keyboards, and gel bottles, just to kind of see where what are the risks and where are they happening. And so what they found was that the TA probes, that they were like 3% of those were contaminated. The transvaginal probes, 4% were contaminated after low-level disinfection. They did find some environmental spore-forming bacteria, but what was reassuring to know is that they did not find any growth in those probes that had received high-level disinfection. Keyboards and the electrical cords, so often those transducers they're not wireless, so they're connected to a cord. 80% of those were contaminated after use, and so this is a really important source of potential a potential reservoir for infection. And then just sort of noting the different types of pathogens that they found there. So I think probably the EFACM is probably the most significant one for us that we are always concerned about. And then again, heated ultrasound gel, 42% had environmental pathogens in it. And so heating of the ultrasound gel is a pretty common practice, particularly in areas where people are being very sensitive to how cold the gel is. So you'll often see it being heated in OB areas, anywhere that there's doing sort of an abdominal ultrasound. It's more comfortable and it's a satisfier for the patient. However, it does pose a potential source of infection. And so again, they need to be, those areas, those stations need to be cleaned. Things shouldn't be allowed to sit on there for days on end. They can actually also get quite hot. And so it's just important to be aware of them. And so I always recommend that people take a look at those stations. Often we're just looking at the machine, but really going and looking at where they can, where they're storing their gel and how they're heating it. I actually had an issue. The heater station was always just covered in gel and dirty, and so I was actually rounding with a consultant that had come for survey prep, and she picked up one of the bottles. It was super hot, and it actually when she picked it up and sort of squeezed it, it actually sort of exploded over her, and so that was an immediate needing attention item. But it was really important just to, and highlighted how easy it is when things are not necessarily used frequently, that they can sit in. Obviously something that's warm and moist is a perfect environment for bacteria and other organisms to grow. So we also have portable equipment. And so this is just a study that was looking at how we look at our portable patient equipment. And so they did look at some of the different types of scanners that are out there. And so they used the ATP, so that bioluminescence assay, to evaluate the cleanliness of in an inpatient area. They used 8 acute floors and an emergency room. And so they looked at their baseline results. So they did all this, they screened and used the assay on everything before they implemented their cleaning processes. And so what I thought was interesting, they looked at a lot of different areas, but what I really wanted to highlight was the bladder scanner. So if anyone is familiar with the ATP, it uses relative light units as a measure. And so typically the range, per the manufacturer, for a dirty surface, you would expect to see it greater than 250, and a clean surface would be less than or equal to 250. So they went and swabbed their bladder scanner, and it was like well over 1,000, and you can actually see the range there. So an item that probably didn't get too much cleaning. And then their ultrasound machine was also pretty high, and certainly well above their cleaning surfaces. And so this was obviously an area where they were implementing some process improvements around cleaning. But it's a great way, and I think it highlights how easy it is to take something like the equipment that is often used between patients and really evaluate how clean it really is. So this is another study that was done by Ruth Cario, and this is actually it's kind of an interesting study. What they did is that they looked at YouTube content that was based on, sort of showing educational videos, and they looked at these and analyzed them to investigate whether contact with a puncture site occurred during a routine procedure. And so they used Spalding's rationale regarding critical versus semi-critical device, and they looked at the distance between the ultrasound probe and the needle or the puncture site. And so what was very interesting is that most of the procedures that they reviewed fell into category A. So there was clear contact between the needle and the puncture site. And then she found that 43% of biopsies fell into category A and 48% fell into category B. So again, very close proximity, less than 10 millimeters. Nerve blocks were another common procedure. 31% fell into category A and 41% into category B. Drainage, so 50% of those fell into category A and 41% into category B. And then central line insertion was similar, with the majority happening in category A. And then 50% of peripheral vascular access, so this included both PICC lines and peripheral IVs, were also in category A and category B. And so I thought it was really interesting that a lot of times when we're asking, when we're looking at procedures and we're asking that they use a probe cover, that people's perception of how close they are to the insertion site or the area is often misjudged. And so I thought that was very interesting that only 10% of what they looked at was not in very close proximity. So again, just some ideas to kind of think about how these the ultrasounds are being used, and if we've got them adequately, if our patients are adequately protected during these types of procedures. So this was another study that looked at variation in reprocessing. And so it's a pretty recent one. It was published early last year. And so this one was kind of an interesting one. They looked at 55 encounters across 24 specialty clinics. So it wasn't a huge study, but I think that this is really one that it was really a write-up or an article of a process improvement project that they did within their facility. So again, it has some really good information for us to be able to take away and maybe consider using in our own areas. So table 1 looks, which is the bigger box there with the table on it, provides information on the ultrasound probes with the potential to have contact with sterile tissue. And I think it's interesting that most of those went under just low-level disinfection, so 43%, or no disinfection, which was again 43% before they were used. And after use, most probes went under low-level disinfection. And so thinking about the types of procedures that in the previous slide, how close they were to those insertion sites for biopsies, for nerve blocks, for some of our other different types of procedures where they're using needles. I think that this is important information. The other thing that they noticed was that the practice of using the same probe to scout the patient's anatomy prior to the procedure. So that's a pretty common thing. If you've watched ultrasound or a procedure, they'll often sort of like, review the sort of like check out the area, make sure their anatomy is great before they actually do the injection or have that contact with sterile tissue or blood. And so what they found in this particular studies, that where this happened, they actually classified 9 of the occurrences as having no disinfection. So they probed, and then they did the insert without any disinfection before use. And so Again, they also found there's a lot of variation about who was using sterile gel for these procedures. So only 38% of them were using a sterile gel, and 52% were using sterile covers. And so again, looking at this information in the context of that previous slide with the images, I think it really highlights that we still have some ways to go in making sure that we're using the right equipment, to barriers, and then also the right types of disinfection for the type of work that's being done. So this is just, again, it comes from this AJAC article, but it's just a really nice graphic of sort of like a way to sort of determine what the ultrasound probe is going to have contact with during the procedure, and then the type of recommendations, and sort of taking accumulation of the CDC guidelines, the AMI guidelines, and the sort of ultrasound guidelines to be able to kind of put together this little table. So really kind of reinforces that if something is having contact with sterile tissue or the bloodstream, then it should be sterilized or at least high level disinfected. And then if it's considered to be semi-critical, again, high level disinfection. And then if it's only having contact with intact skin, then low level disinfection is an appropriate option. So I wanted to touch a little bit about sheaths. So these are the sterile covers that go over the probe when they're being inserted or close to a sterile area. So the CDC has some guidelines around it, and so does the FDA. And so the CDC recommends that all endocavity probes without a probe cover are semi-critical devices because they have direct contact with the mucous membranes. And so they propose that a new condom or probe cover is used for each patient. And again, even with that cover, the probe should still be high level disinfected. So one of the things that I've come across is that people don't always know that there's sheaths available, or they want to use something else. So I have seen the probes be put into a sterile glove to sort of meet this cover, or they'll put a techoderm over it. Neither of those are really meeting the intent of protecting the patient. It's really just a stopgap measure. And so really, again, making sure that that they should be used, and if regardless of whether the sheath is used, they still need to be appropriately high level disinfected or sterilized. And then the FDA, sorry, also has some recommendations really describing what type of disinfection the probe should go through, and then when a sheath is being used. So again, if you're getting any pushback from departments, these can be some good resources to help facilitate some change in that area. There's also a number of different toolkits that are out there. So this is the Infection Prevention Toolkit. It contains a number of different types of tools and resources, and they're really designed to help design and sort of boost your policies and procedures around ultrasound. So it's broken up into 4 different sections. So they look at, the first tool is really looking at where your ultrasound is being used. So looking at how to identify it. So there's some recommendations and some ideas around how to track down where they're going, and then identifying where they are and what they're being used for. Then there's tools for identifying what type of disinfection is required. Then it's looking at the potential hazards, so the ability to do a risk assessment, so that you can really hone in on some of those high risk areas, and then provides a framework for identifying policies. And so this has been around for a few years now, but it's actually a great tool, particularly if it's an area that maybe hasn't had the priority or resources put to it previously, this is a great place if you're looking for somewhere to start. And that is the end of the presentation. So again, Zach will be sending out the links, but this is just highlighting the link and stuff for your CEs. There's a huge reference list here, and again, you will receive this after the presentation when Zach sends it out to you all. And so, any questions or discussion in the few minutes that we have left around ultrasound or anything else that people might be doing? Has anybody been working on an improvement process, specifically looking at your ultrasound equipment, or have done one recently? If anyone wants to put into the chat. Let's see. Janine mentions that, yes, with large facilities, it makes it hard. Janine, I'm curious, did you find ultrasounds in places that being used in places that you didn't really expect? And if you're able to take yourself off mute, you're welcome to do that as well. And I see a comment from Mary. Did your MSN capstone project on disinfection of ultrasound probes used for venous access? I'm really curious, Mary, what were your findings from that? And Janine mentions that just reminding the staff and providers to clean after use and when to high-level disinfectant. It's only on a computer. It's okay. Appreciate your taking the time to type that in. And so Mary mentions that her findings from her project were that no probe covers were being used. We set up use of probe covers and ensured we were following manufacturer's instructions for cleaning. That's great. And there's a lot of different areas. I spent some time working in a post-acute rehab facility, and so there was ultrasound being used. We had bladder scanners. We had did a lot of Dopplers. We had a physical therapy department, so ultrasound was being used there. But we also had a pain clinic, and so there was a lot of ultrasound being used there for joint injections and things like that. Some providers use the fluoro, but others prefer to use the ultrasound, and so there was a lot of opportunities around the sheath use for many of those areas, because they were not, they were using the techoderm route, which was not necessarily very effective. So Janine mentions that they did not to high-level disinfect after percutaneous procedures such as in line insertion. We do require high-level disinfection if the sheath is damaged or fluid is noted on the probe after sheath. So I think, again, really looking at the types of procedures and knowing that, even like just going back to those CDC guidelines and the FDA comments, and if that, regardless of if the sheath is being used or not, that it still should be high level disinfected if that's if it meets that particular criteria for semi-critical use. So sometimes you have to really go and see how they're being used. A lot of times, I think providers and people who are using them during the procedures, they don't even appreciate how close they are. But again, just following the manufacturer's recommendations and the CDC and FDA guidance, going back to that. But it's a good question. And I think that you're not alone, because, depending on how frequently, there's always pushback for the frequency of the procedure and the time it's going to take in order to, and the work that's involved in the reprocessing of them. So I think it's important to kind of think. And so I know that for line insertions, a lot of people aren't. And I think if it's being used to identify the vessels and it's not, being used in close contact, like if it's not in close proximity to where the insertion is happening, then I think that will really be your just determining factors. And so if you use that model, then you would probably have sometimes where it might need high level disinfection, and other times it may not be. So again, kind of doing a risk assessment would be another idea to kind of think about that. But I think for most, I would say that most PIC teams are not for example, are not high level disinfecting their probes after use. But I think it really depends on, again, how close in proximity they are to the insertion or to non-intact skin. Good question. I see there's a few questions in the Q&A section. So the slides are not available, but the list of references contains everything that was in here. So links to the FDA recommendations, CDC guidelines, all of the articles, they'll all be available for you. The typical expiration date after opening the gel bottles, there's usually an expiration date on the bottle. We tend to use the sort of standard rule of like what you do for your medications. And then just, if it's outside of that, that's probably the best, it's best to dispose of it, because typically if there's a high turnover, the gel goes through pretty quickly. So it's really those ways that are where it's not used frequently and they're sitting for long periods of time. The other thing that happens too is that sometimes, how people, if that gel bottle has contact with the skin, if they're not very careful about how they, apply it, there's a potential for the top of the bottle to be, that opening to be contaminated. And then also just thinking about where those bottles go. Like, so do they take, if they take the same bottle that goes into an isolation room and then it comes out and then is used on somebody else, or do you have separate bottles that are just for that particular patient, or are you using single use for those types of situations? So again, a good question about that. But and what I did in my place is we just kept kept it simple so that everything was the same sort of as what the pharmacy was. So that 28 days was how we did it for ours once they were opened. Another question is there a more preferred way to store the single-use gel bottles? We frequently see them stored upside down. That's how I've seen them stored too. I think probably, storing them right side up, particularly if they're in the holders, like if they're in those warmers, because when the gel is warm, it's not as thick, and so it's more likely that it's going to leak into those stations. So, but typically when they're in use, they are upside down. I think making sure that people, cover them. So when you go past if you see an ultrasound machine, just pull the bottle out and see if if the tip of it's covered or not. It's not that hard. I mean, you could change practice to like have them keep it up the other way. It's not that difficult to turn it upside down and give it a shake to move it to the head of the bottle. One of the facilities I went to, we just decided to go to the single-use non-sterile because the bottles were everywhere. And so they weren't being stored appropriately. And after we had our sort of like overheated gel explosion all over our consultant, that was pretty much the final straw. So I was pretty happy from an infection control perspective that we were just going to the single use, because we were using them for the bladder scanners. They were using them for the Dopplers that were being done. And they were, another group that was coming into the facility to do them. So it just ended up being a better solution for our facility, and cost-wise, it really wasn't that big of an issue. And then, as it turned out, again, working with purchasing, it ended up that it became a standardized across the board that all departments just used the single use and they got away from the bottles. So, but I think just, it's just one of the things to take a look at, is just to sort of see where and how those bottles are being stored. So, good questions. We just have a couple more minutes left. If anyone has anything else I'd like to share, any experiences, or learnings perhaps that they'd like to share with the group. It's always great if you've had a lesson learned that you can share with someone else. Save them a pitfall. One of the other, I don't think it's happening too much now. I think most places have probably moved away from the glutathione, particularly for the vaginal probes. But it was an issue, certainly when they were being used, when it was being used, is that staff didn't always know how to manage the probes. So I'd actually come across times where people were not rinsing the probes properly before they were using them. So they were using the glutathione, they had them sitting in their little, tubes, and there was a lot of focus on, people did a great job about the testing of the solution and making sure that it was, the test strips were dated and all of that piece was looked good from that perspective. But when we talked to the staff about how they were actually using the probes, it turned out that they were not actually, they didn't know to rinse them correctly. And so that was another area that we didn't expect to really find an issue. But when usually what happens, like peeling an onion, right? It's like you take off one layer and then there's something else that's underneath. But that's often, again, if people are not necessarily, if they're doing it in their own departments, just making sure that the whole entire process people are knowing the correct procedure for. And that is us at time. So I will hand us back to Zach. Thank you, everyone. Appreciate it.
Thank you, Carrie. That was great. So right now I will, once I get the list back from Zoom, I will be sending out the reference list and the survey you need to fill out for your credit. If you need something a little more specific as an answer, feel free to ask at any time. We can definitely find that for you. And if you have any other questions, please don't hesitate to reach out. Other than that, have a great rest of your day. Thank you.
Thanks, everyone.